This is part two of a two-part series on the basic pharmacology of inhaled anesthetics as part of the University of Kentucky Department of Anesthesiology didactic series. My name is Randall Schell. Let's go back and look at the American Board of Anesthesia IT keywords related to the topics that we're going to talk about in this second part. We're going to talk about some of the physiologic effects of the inhaled anesthetics on the brain, oxygen use by the brain. It decreases it. CNS effects, it increases cerebral blood flow and decreases cerebral metabolism. Desflurane, probably related to its adverse cardiovascular effects of stimulating the sympathetic nervous system when rapid changes in concentration are made. Bronchodilation, the fact that our inhaled volatile anesthetics are all bronchodilators. That upper airway irritation can occur with a desflurane. That our inhaled anesthetics reduce tidal volume and increased respiratory rate as the normal response to spontaneous ventilation of inhaled volatile anesthetics, that the ventricular response to hypoxemia in the presence of inhaled anesthetics is greatly impaired, even down to approximately 0.1 and 0.2 Mach, that our inhaled anesthetics potentiate neuromuscular blockade. The volatile agents, our TIVA agents like remifentanil, Propofol do not, and nitrous oxide does not potentiate neuromuscular blockade, unlike Sevo, Des, and Isoflurane, which do. Toxicity and metabolism issues, as well as the disease MH, the volatile anesthetic toxicity. Normally, we talk about what happens in the CO2 absorber, the heat that's generated, the potential for carbon monoxide to be generated with desflurane specifically, isoflurane a little bit less, and compound A with sevoflurane. And then we'll finish up with nitrous oxide, how it expands closed air spaces, bubbles in your eye of sulfur hexafluoride that can be used in ophthalmologic surgery, bowel distension, etc. So going back and review for just a moment, desflurane, remember, has very low potency. It requires over 7% or so to provide 1 Mach, or 50% of patients from not moving to incision at the alveolar concentration of 7.25% at 1 atmosphere and 20 degrees. Very low blood solubility, meaning that its FA over FI, its onset is rapid. It's the least metabolized of all the volatile agents. It has to have that special vaporizer plugged in, heated to 39 degrees centigrade, which creates an environment of about 2 atmospheres pressurized desflurane to accurately deliver desflurane. High vapor pressure, new vaporizer required. Airway irritant, upper airway irritant, when you turn up concentrations rapidly or high, airway irritation can occur. We usually use desflurane not for induction, but for maintenance of anesthesia. Sevoflurane, however, even though it's not quite as insoluble as desflurane, it also has a fast onset and offset. Its potency is more potent than Des, and about 2% is the Mach, as opposed to 7% for desflurane. Because of its pleasant smell, relative pleasant smell, and non-irritating to the airways, you can turn on relatively high concentrations and breathe sevoflurane, and it can be used as an inhalational induction. In the case of a child without an IV, for example, single breath inductions can even be done in adult patients. In fact, in an older study where they compared the vital capacity induction with sevoflurane to our gold standard of intravenous induction with Propofol in adult ambulatory patients, basically, sevoflurane produced faster loss of consciousness. Side effects, recovery times, and patient satisfaction were similar to that of Propofol, so it can be used, however, in adults, usually an IV induction agent such as propofol, etomidate, ketamine, barbiturate, or some other drug is used to induce general anesthesia, and our volatile agents are used to maintain anesthesia. Isoflurane is even more potent than both Sevo and Des at about 1.2% Mach, Its solubility is higher in blood, therefore it has a slower onset and offset than does Sevo and Desflurane. It's relatively inexpensive. It's pungent and not used for inhalational inductions, and usually used for maintenance with a little bit slower recovery than Sevo or Desflurane. Let's change gears now and talk about the physiologic effects of inhaled volatile anesthetics. This is a little bit difficult to talk about because many of the studies that look at what the inhaled agents do to humans are performed in young, healthy volunteers. And I rarely take care of young, healthy patients in my practice, and probably in yours, you do not either. So young, healthy volunteers, what happens physiologically under different MAC concentrations of inhaled anesthetics may be affected by the coexisting diseases of the patient, whether they have good or bad LV function, that is, how old they are, how much stimulation surgery is going on, how long they've been hypovolemic, NPO, for example. What if they're taking a beta blocker? They're not going to get the same reflex tachycardia that they would probably without the beta blocker. What if they're taking vasodilators? May drop the pressure more. So you can see some of the complicating factors when we compare physiologic effects of inhaled anesthetics. That being said, let's do our best to go over the characteristic physiologic effects of inhaled volatile anesthetics. Up at the top, you can see that blood flow to the head increases. These agents, Sevo, Des, Iso, are vasodilators, and they cerebral vasodilate, so blood flow to the head goes up. ICP can go up, although hyperventilation will blunt that, and metabolism to the brain, because the brain cells are going to sleep, using less oxygen, goes down. So blood flow is going up as metabolism is going down. Normally they go in the same direction. Looking at the respiratory system, if a patient is breathing spontaneously, for example with a laryngeal mask in, or an endotracheal tube in, with Sevo, Des, or Iso on, they will often breathe with a very rapid rate, a low tidal volume, and their alveolar ventilation is reduced because more goes to dead space as the tidal volume goes down, so PaCO2 goes up. So the classic LMA patient who's got a respiratory rate of 25, a tidal volume of 200, 250, and an end-tidal CO2 of 50 to 55. All of our volatile anesthetics are bronchodilators. They have muscle relaxation effects, that's excluding nitrous oxide. They tend to drop the blood pressure by vasodilation, bottom right here, and usually cardiac output is actually maintained, even though it shows a decrease in this graphic representation. So let's look at some data in healthy volunteers, that is. This is mean arterial pressure on the y-axis and MAC on the x-axis. So as MAC goes up, the amount delivered to a patient, you can see that mean arterial pressure drops significantly, and it does so for all volatile anesthetics, and you'll be hard-pressed to tell the difference between one or the other. So MAP goes down. Well, if it goes down, why is it going down? And so let's look at the math equation for MAP, which is equal to cardiac output or flow times a resistance, systemic vascular resistance. If our MAP is going down, is it cardiac index or SVR? Well, if you look at a cardiac index, excluding halothane in the square box here, you can see that cardiac index tends to be maintained even at high MAC concentrations. Again, excluding halothane, which is mostly historical, you can see that our inhaled volatile anesthetics are vasodilators, while halothane was not. It was a cardiodepressant, non-vasodilating inhaled anesthetic. But blood pressure then drops mainly because of vasodilation. What happens to heart rate? Again, you can see if we exclude halothane, heart rate tends to go up reflexively as blood pressure goes down to maintain cardiac output. If you rapidly increase the concentration of desflurane, the sympathetic nervous system can be stimulated, and the graphic on the left shows heart rate in beats per minute versus time with rapid changes in concentration of desflurane in control patients, with the biggest change here in heart rate. Those that were given small doses of fentanyl with it being blunted, and larger doses of fentanyl blunting much of that tachycardia that occurs with the rapid increased concentration of desflurane. So if heart rate goes up, why is it going up? And if you look at norepinephrine levels on the far right, you can see that desflurane, rapid changes in concentration, for example, moving from 0 to 12%, and watching the patient's heart rate, it will go up, norepinephrine levels will go up, but this does not occur for a very long period of time. In fact, this cardiovascular stimulation induced by the rapid increases in concentration of DES, mainly ISO also, however, fatigues, such that if you kept doing this over and over with time in between, there'd be a less effect when you repeated it the next time. Probably has something to do with activation of tracheopulmonary and systemic receptors. Why systemic receptors? Because if you deliver desflurane through a cardiopulmonary bypass machine and do the same thing of increasing the concentration, therefore you're delivering it to the blood, you can still get the sympathetic nervous system stimulation. So it probably isn't just the upper airway receptors, but probably some systemic receptors also. It's attenuated by pre-treatment with alpha-2 agonists or opioids, fentanyl being the classic small doses of fentanyl. We tend not to see much of this effect. Coronary steal is the concept of where you have an anatomy set up, such as in this picture, where you have total occlusion, in this case of an LAD, while the circumflex is not totally occluded. And if you give a drug that causes vasodilation of epicardial vessels, vasodilation can occur in the non-totally occluded coronary arteries like the circumflex and actually steal blood from the ischemic area, which is maximally vasodilated already before you turn on the volatile anesthetic. And so instead of giving to the poor, taking from rich and giving to the poor, you're stealing from the ischemic area and giving it to the good area, which vasodilates to these epicardiovasing dilating volatile anesthetics. And this was a worry some time ago. Can volatile anesthetics cause coronary steal in patients with steal-prone anatomies such as this? And really, there's been no difference in outcome when patients undergoing coronary bypass surgery who are at risk for myocardial ischemia, even those with this steal-prone anatomy, receive inhaled anesthetics versus intravenous anesthetics. And this does not seem to be a real clinical concern. So we'll leave it at that for now. Myocardial sensitization to catecholamines. Many surgeries may have concomitant administration of drugs such as lidocaine with epinephrine and local anesthetic, other local anesthetics with epinephrine. And years ago, when halothane was used, it was shown that when relatively small doses of epinephrine per kilo body weight, you could see in the range of about 2 mics per kilo. That's only 2 times 70 kilogram person, 140 mics. If you have 5 mics per cc, a 1 to 200,000 dilution of epinephrine, like in a regional anesthetic, it's really only about 30 cc's, which you could put in for some of your blocks in certain areas, that you would get ventricular extrasystoles if the patient was breathing halothane, while as opposed to isoflurane, it took much higher doses. And DES and ISO, when you compare the two, they require very high doses of epinephrine so to cause these extrasystoles in the presence of the volatile anesthetic. So really we think of halothane as being the one that sensitizes the heart to catecholamines, and our other volatile anesthetics as not being an issue. Some other cardiac issues, a QT interval prolongation is present in some patients. There are some patients that have sodium channel problems, long QT syndrome patients. And this QT interval that should not usually be longer than about 0.44 in a male and about 0.45 in a female. When it tends to get long, some of our drugs can actually prolong it, like our antiemetics. There can be RNT phenomena, there can be risk for torsades de points, and there's worry that our volatile anesthetics, which actually do it, prolong the QT interval, might worsen this in patients with long QT syndrome. But patients with long QT syndrome are usually treated with beta blockers, and it's been quite well shown that if those patients with long QT syndrome are concurrently treated with beta blockers, they've been safely anesthetized with all of our modern volatile anesthetics. So do they prolong the QT interval of volatile anesthetics? Yes, some. Is it a clinical problem? Doesn't seem to be a huge one. This concept of preconditioning is basically saying that there's some protective benefit of a volatile anesthetic against myocardial ischemia. That is, if you precondition the heart by exposing it to a volatile anesthetic and then cause ischemia, there is less ischemic damage than if the volatile anesthetic was not present. So it has a protective preconditioning effect, and volatile anesthetics have been shown to enhance ischemic preconditioning. And this is probably related to mitochondrial ATP-sensitive potassium channels, but that's as far as we need to talk right now about preconditioning, I believe. So, summary of the cardiovascular effects. The inhaled anesthetics are vasodilators, cause a reflex increase in heart rate as the blood pressure drops, and cardiac index tends to be preserved. The mean arterial pressure tends to go down the same at similar MAC concentrations for all volatile anesthetics. All of them are vasodilators, excluding halothane. All of them increase the heart rate somewhat, excluding halothane. Sympathetic nervous system is stimulated by desflurane when its concentrations are changed rapidly. Isoflurane a little bit less, Sevo and halothane much less. Dysrhythmias, that is sensitization of the heart to catecholamines, is associated with halothane. Coronary Steal doesn't seem to be a big issue, and preconditioning is something that volatile anesthetics do, protection against myocardial ischemia. Interestingly, when we add nitrous oxide to replace a volatile agent, i.e., let's say we decrease our isoflurane concentration from 1.2%, which is 1 MAC, to 0.6%, which is a half a MAC, and we add approximately 50% nitrous oxide, a half MAC of nitrous oxide. So 1 half MAC plus 1 half MAC, we're back up to 1 MAC, but you'll get less decrease in blood pressure because we've substituted an agent, nitrous oxide, to provide part of that MAC, which doesn't have those vasodilatory effects that the volatile anesthetic does, and we'll get less physiologic change in blood pressure. What about the respiratory system? Patients tend to breathe with a lower tidal volume and a fast respiratory rate, that is panting. And as they pant with a lower tidal volume, let's say instead of 500 it goes down to 250, the dead space, anatomic dead space, which is normally approximately 1 mil per pound or 2 mils per kilogram or approximately 150 cc's in an adult patient, doesn't change. And so if 150 is dead space and 250 is the total tidal volume, you can see that more than 50% of ventilation is going to dead space with a low tidal volume, as opposed to a normal VD over VT, dead space over tidal volume, of approximately 150 over 450 over 500 being approximately 1/3 or 30%. Airway resistance is reduced by all inhaled volatile anesthetics, they're bronchodilators, and the response to elevations in CO2 or decreases in oxygen levels are greatly affected by inhaled anesthetics, oxygen especially. So if I took you and put you in a room and gave you a volatile anesthetic with an LMA, breathing spontaneously, and then turned up the carbon dioxide delivered to you, you normally would breathe much, much higher alveolar ventilation. Minute ventilation, alveolar ventilation would go up. Volatile anesthetics block that ventilatory effect to increases in CO2. Only takes a little bit of inhaled anesthetics on board to block the hypoxic response. So again, if I took you in a room, had you breathing through an LMA under volatile anesthesia, and then turned down the FiO2 below 21%, let's say down to 12%, normally you'd breathe like mad, hyperventilate, and under volatile anesthetic, this is blocked dramatically. So the central and peripheral chemoreceptor function is depressed in a dose-dependent manner with inhaled volatile anesthetics. And this older study shows that, and here you can see that the ventilatory response to acute hypoxia at 0.1 max. I mean, we're talking very low concentrations of inhaled anesthetic, and look what they do to the ventilatory response to hypoxia. We're talking approximately 50% reduced, so there's profound depression of hypoxic responsiveness by the inhaled anesthetics. Clinical application of this is, what if you had a patient in the recovery room who is still exhaling sub-MAC concentrations, sub-MAC awake concentrations of inhaled anesthetic, and became hypoxic? They would not breathe as rapidly and would not have the hypoxic response that you would expect. Some other respiratory effects of inhaled anesthetics: they inhibit mucus clearance, pulmonary vascular resistance. There's a small decrease with ISO, DES, and SIVO, small increase actually with nitrous. Hypoxic pulmonary vasoconstriction, or the vasoconstriction of blood vessels going past alveoli with lower alveolar oxygen, partial pressure in that alveolus. That's called HPV. There's modest inhibitory effect of this HPV with inhaled volatile anesthetics, but most will say that this is a relatively minor effect and really doesn't influence clinical decision making much. However, some thoracic anesthesiologists who are having problems with oxygenation on one lung ventilation with volatile anesthetics sometimes will say, well, let's start a TIVA anesthetic because it doesn't have a much effect on HPV. But I think really we need to remember that this is just a modest inhibitory effect that our volatile anesthetics have. Now, apneic threshold is the highest arterial CO2 tension at which a subject remains apneic. This level is increased by volatile anesthetics. Therefore, if you had a patient breathing through an LMA, Sevoflurane, for example, and their end tidal CO2 was 55 and they're breathing along, and you said, I don't want it to be 55, I want it to be 45, and you take over and ventilate them down to 45, many times they won't breathe until their end tidal CO2, their arterial CO2 that is, rises again, and they have a stimulus to breathe. So the apneic threshold, the point at which the subject remains apneic, is increased with volatile anesthetics. In the brain, the blood vessels are vasodilated like they are in the systemic circulation. And as those blood vessels vasodilate, the blood flow to the head goes up. At the same time that the cells are going to sleep and the oxygen requirements are going down. So we have blood flow going up and metabolism going down in an opposite direction. And if you have very high concentrations of inhaled volatile anesthetics without hyperventilation, you may have some problems in patients with traumatized head, for example, with ICP and raising ICP. When you are using somatosensory evoked potential monitoring, for example, scoliosis back surgery, if you're using a volatile anesthetic, it will, in higher concentrations, take the signal to get longer through the neurologic pathways, and it will come through with a lower amplitude, making it more difficult to monitor. Therefore, SSEPs, especially if combined with motor evoked potentials, tend to move away from volatile anesthetics and towards a TIVA such as propofol, remifentanil anesthetic. Now, SSEPs alone, if you're using those alone, you can use sub-MAC concentrations combined with an opioid infusion, even use neuromuscular blockade with SSEP. We would not with MEP monitoring and get away with it. So inhaled anesthetics do not abolish cerebral vascular responsiveness to changes in PCO2. In other words, when you hyperventilate a patient and drop the CO2, we know that when we do that to patients with high ICP, we do it in an attempt to reduce the intracranial pressure by reducing the cerebral blood volume. And hyperventilation will do that very quickly, but over very short periods of time before equilibration occurs. So this hyperventilatory effect on PCO2 and cerebral blood flow occurs under volatile anesthetics also. Neuromuscular effects, you get relaxation of the muscle with volatile agents, not like rocuronium, but it actually potentiates rocuronium's effects. So if you were using rocuronium with Desflurane, SIVO, or ISO, and you wanted to keep a patient at 2 twitches, for example, it would take less rocuronium to do that than if your anesthetic was, let's say, propofol, remifentanil, or propofol nitrous, or remifil nitrous, remifentanil nitrous, propofol, or something like that. So volatile agents, skeletal muscle relaxation, potentiation of neuromuscular blocking agents, both non-depolarizing and depolarizing. And at the end of an operation, when the volatile anesthetic is blown off, it will speed recovery along with our usual reversal agents like neostigmine. All of our potent inhaled agents can do some bad things in the muscle, and that is trigger malignant hyperthermia. So let's talk briefly about malignant hyperthermia. In patients that are genetically susceptible, the ryanodine gene seems to be important here. There's autosomal dominant variable penetrance genetic susceptibility. The incidence varies between countries, but fulminant MH occurs in about 1 in 250,000 anesthetics, which means most anesthesiologists are not going to see malignant hyperthermia in their lifetime. I graduated from medical school in 1987, was doing anesthetic cases prior to that as a medical student. So in the last almost 30 years, I've never seen a case of MH in operating rooms of 2 academic centers in the United States. That being said, when it occurs, there's a high mortality without the use of dantrolene. And the anesthetic trigger for malignant hyperthermia is our inhaled volatile anesthetics plus or minus succinylcholine. The volatile anesthetics alone, succinylcholine alone, or both in combination can cause a trigger of MH. The picture up at the top right is a girl who underwent surgery in Florida. This girl, when she underwent surgery in an outpatient surgery center, apparently had the onset of malignant hyperthermia. Dantrolene was attempted to be mixed up. It's very difficult to mix up dantrolene. Apparently there was problems with mixing it up. She was transferred to another hospital, and by the time they got dantrolene in, unfortunately, she passed away. So MH is still, even in this modern era, is potentially fatal. It used to be about 90% fatality without dantrolene. Now we think of it as about 10% mortality because we have a drug, dantrolene, which affects calcium metabolism, and calcium is the problem inside the cell. So the upper right graphic shows what's going on in MH, where you have a sarcoplasmic reticulum, SR, a ryanodine receptor, RY, and the RY is spewing calcium out into the cell, and the actin myosin filaments are crossing, and you have rigor of muscle, and as that muscle contracts, it creates heat, produces carbon dioxide, and there's anaerobic metabolism going on, and lactate production, so respiratory and metabolic acidosis occurs. And the high levels of calcium, unless you can stop that, result in often fatality of a patient who develops this full-blown episode of MH. Dantrolene, however, stops the ryanodine receptor from spewing out the calcium and leaves the SR able to take up calcium from inside the cell, so levels will drop of calcium and hopefully have resolution of the MH episode that has been associated with muscle rigidity, muscle damage and death, rhabdomyolysis, respiratory acidosis, hyperthermia, and cardiac dysrhythmia involvement, not infrequently. Let's shift gears for a moment and talk about toxicity and metabolism in inhaled anesthetics. In the air around us as we're delivering it, there are trace concentrations. If you smell a volatile anesthetic, it is way, way, way over National Institute of Occupational Safety and Health trace gas recommendations. So when you're doing a volatile anesthetic induction, say for example with Sevo, and you are smelling it, there is a lot leaking into the room, and you're above the classic 2 parts per million, which is supposed to be the allowable trace gas concentration. And if you're using nitrous alone, it's 25 parts per million. And if you're combining inhaled agent with nitrous, the halogenated agent is supposed to be only at 0.5 parts per million. So in your mind somewhere, I'd probably put this 2 parts per million and 0.5 parts per million as the NIOSH trace gas recommendations without a whole lot of evidence to say, what is bad for a patient. Now, in Anesthesia and Analgesia 2001, a paper I found very interesting looked at genotoxicity assessed by the formation of micronucleated lymphocytes or chromosome damage in anesthetists in 2 locations, an Eastern European country and a German hospital. The German hospital very meticulously scavenged the inhaled anesthetic. The Eastern European country, that is, did not, and there were relatively high concentrations in the operating room of the inhaled anesthetic. And it went on to show that, yes, you could see some chromosomal damage at those high concentrations, but at threshold occupational values recommended by NIOSH appeared to be quite safe. So in summary, there doesn't appear to be a risk associated with brief periods of low-level occupational exposure to the waste anesthetic gases in our operating room or other locations. But very high exposures may be correlated with incidence of abortions and decreased fertility, and I say may in a capitalized format. But individuals with B12 deficiencies who are given nitrous oxide, because as we'll learn a little bit later, or you probably already know, that nitrous oxide impairs DNA formation as well as vitamin B12 folate mediated things in our body, and we can get a macrocytic anemia and neurologic damage if nitrous oxide exposure occurs for prolonged periods of time. Immune-mediated hepatic injury, we used to call this Halothane Hepatitis. Halothane is, again, of historical significance mainly. Halothane is shown in the top left here, an alkane with halogens around it. In the liver, there was what was called a trifluoroacetylated antigen formation when some patients were exposed to halothane. There's 3 fluorides on that acetylated compound, which is bound to the hepatocyte. The body sees that TFA antigen as, that's not me, and when exposed to halothane again, developed an immunologic response resulting in liver cell death. And halothane was the bad actor here. ISO-DES, extremely low incidence, case report type, and SIBO, extremely, extremely rare, if ever. And clinically, the immune-mediated hepatic injury presents like an immune reaction, eosinophilia, fever, rash, arthralgia, prior exposure. It seems to occur more in females who are obese, multiple exposures, and not so much in children. So we think of this hepatic injury from volatile anesthetics being associated with halothane in an immunologic manner, but the newer volatile anesthetics, extremely rare to have any problems with them. So if a patient in the postoperative period has elevations in liver enzymes, your first response should not be, I think this is immune-mediated hepatic injury or Halothane hepatitis. Another problem with volatile anesthetic metabolism is carbon monoxide formation, specifically with desflurane, but also with isoflurane, desflurane being the worst actor. Desflurane in the presence of the CO2 absorber when it's dry. So this is not metabolism of desflurane in the patient's body. This is desflurane in the CO2 absorbent in that hot alkaline environment. If it's very dry and gets up to a high temperature, especially with bear lime, which you're not going to be using, but soda lime can also do it, you can get carbon monoxide formation. When carbon monoxide is formed, you usually won't even know about it because your pulse oximeter will not be able to detect that. You'll have a falsely elevated SpO2, while if you drew a blood gas and sent it off, you would see that your SaO2 is actually decreased, and some of your hemoglobin has carbon monoxide bound to it, or carboxyhemoglobin. Sevoflurane is another potential issue of metabolism, specifically compound A formation. Compound A you can see in the middle of this blue square part, sevoflurane being broken down to it, in the presence again of the high temperature, low water content, low humidity, CO2 absorber. So sevoflurane breakdown to compound A is not occurring in the patient's body, it's occurring in the CO2 absorber. That compound A that can occur if you have low fresh gas flows, usually we keep it at 2 liters or more, high sevoflurane concentrations over long periods of time, in a low water content CO2 absorber, and bear lime was a worse actor than soda lime historically, then you could get compound A formation. Who cares? What if compound A is formed? Well, in rats who have an enzyme called lyase, they had renal dysfunction, killed their kidneys basically. And you can see here that if your fresh gas flow was increased from relatively low fresh gas flows of 1 liter per minute up to higher gas flows of 6 liters per minute, compound A concentrations that could be measured in the patient were much, much lower. Actually, it was being removed from the circle system. So there was an FDA requirement for higher fresh gas flows. We usually keep it at 2 liters or more. But does compound A kill our kidneys? And it was nephrotoxic at 50 to 100 parts per million in rats, but in the late 90s it was shown that, by EAGER, that there was a transient rise in some indices of renal injury, no change in creatinine clearance, and by Evan Karash, that there was no difference in indices of renal function and injury. And I think it's pretty much put to rest that sevoflurane and this compound A nephrotoxicity is not a big clinical issue. Well, what about fluorinated volatile anesthetics and that free fluoride ion that can be pulled off? And historically, that was a problem with methoxyflurane, which, if fluoride metabolism occurred, that is, metabolism of methoxyflurane with release of free fluoride occurred, and if it got more than approximately 50 micromolar per liter, this magic number, ADH effect on the kidney, the collecting tubules, was blocked, and you had a high output renal failure because you were not reabsorbing water. So blocking the ADH effect, nephrogenic DI type pattern. If you look at the free fluoride ion in the graphic on the bottom left, I put in yellow to represent sevoflurane the dark filled circles showing that serum fluoride levels do get up relatively high with sevoflurane. Not at the 50 micromolar level necessarily here, but higher than N-fluorane and higher than our other volatile anesthetics apparently. So the clinical point from this is that, yes, we can get some free fluoride ion, especially with sevoflurane, but it does not appear to cause high output renal failure and is not a big issue. And if you look at sevoflurane and fluoride and renal failure following a patient from pre-anesthesia to day 5 post-anesthesia, there was no change in plasma creatinine when sevoflurane was administered, even to patients with chronic renal disease. Now, the CO2 absorbent is a problem because there's exothermic reactions that occur in it. Some of the variables of influencing the amount of volatile anesthetic degradation include the hydration of the CO2 absorbent. If it gets dry, if you leave fresh gas flows 10 liters when you finish up a patient, wake them up, and then leave the room and don't come back till Monday morning, and 10 liters of oxygen have been going through the CO2 absorber and it's dry, you should change it out and put a new one in. Don't try to hydrate it. DES and ISO, as we mentioned earlier, in the presence of these CO2 absorbers, which are very alkaline and hot, can produce carbon monoxide. Exothermic reactions occur. In fact, if you measure the temperature inside a CO2 absorber with sevoflurane, there's been temperatures up into, I believe, the 300s. There have been case reports of fires. So sevoflurane is the most exothermic causing inhaled volatile anesthetic in that CO2 absorber, has the highest temperatures and the potential for fire. How would a fire or heat in the circle system present? Sudden decrease in delivered sevoflurane, a high temperature absorber, the patient may cough because of the heat going into their lungs, and then a fire. Keep the absorbents moist, change it regularly. As I mentioned, if the fresh gas was left on high, if in doubt and you think it's dry, change it out. In the future, we may get away from the sodium hydroxide, potassium hydroxide containing absorbents, and this may not be an issue. So in summary, from a volatile anesthetic degradation and toxicity point, halothane was the most metabolized of our volatile anesthetics. Sevo are modern inhaled anesthetics. Remember the rule of twos. Halothane was about 20%, Sevo about 2 to 5%, Isoflurane 0.2%, and Desflurane the least metabolized, 0.02%. Carbon monoxide was a problem mainly with Desflurane, although it can be with ISO. Compound A was with sevoflurane, fluoride with sevoflurane, and immune-mediated hepatic injury with halothane. If we look at DES and Sevo, our two main used modern anesthetics, they're both relatively expensive. They both have a relatively low blood gas solubility, DES in the 0.4 range, Sevo in the 0.6 range. DES cannot use a conventional vaporizer. Sevo, you can't use a low flow or shouldn't use low flow because of the issue of compound A and the recommendations. use higher flows. Unlike Des, where we may use a half-liter flows to conserve anesthetic and to conserve heat, Sevoflurane will use 2-liter flows usually at least, and are using it more with the volatile anesthetic and heat of the patient. Desflurane is an airway irritant. Sevoflurane is not and can be used for inhalational inductions. Let's finish up now with nitrous oxide, a short discussion. Nitrous oxide is an inorganic compound. It's colorless and mostly odorless. It's non-explosive, non-flammable, but many people forget that it is as capable as oxygen of supporting combustion, i.e., if you're undergoing laser airway surgery, and let's say you have 80% oxygen on, we all know that we should decrease the oxygen down, usually less than 30%, and as low as we can when the laser is being fired around in the airway near some of our airway devices. But if you had, let's say, 50% oxygen, 50% nitrous, it's important to remember also that nitrous can support the combustion, and that's why TIVA anesthetics often frequently used during airway surgery, one of the reasons, but you can use a volatile anesthetic. Just remember that if it's supported, if your fresh gas flow is oxygen, it should be as low as possible, definitely lower than 30%, and you probably should turn off the nitrous oxide. Some physiologic effects of nitrous oxide: it stimulates the sympathetic nervous system. Remember, our inhaled volatile anesthetics were vasodilators, reflexive increase in heart rate, and really decreased contractility of the heart. Well, nitrous oxide causes release of endogenous catecholamines, epinephrine, norepinephrine. Its direct effect on the heart is interesting in fact that it depresses myocardial contractility, but in vivo, mean arterial pressure, cardiac output, and heart rate may be slightly elevated because of the stimulation of catecholamines, and it can increase pulmonary vascular resistance such that we tend not to use it in patients with pulmonary hypertension. Respiratory system, it will also increase respiratory rate and decrease tidal volume, and has some inhibition of the hypoxic drive. The central nervous system, it can actually increase cerebral blood flow as a cerebral vasodilator and blood volume, and can produce a mild elevation in intracranial pressure. Unlike the volatile anesthetics, it doesn't provide significant muscle relaxation, doesn't have a potentiation of succinylcholine or non-depolarizers, doesn't trigger MH like our volatile anesthetics and succinylcholine, and there's been worry over the many years that it may increase postoperative nausea and vomiting with meta-analysis and multiple studies on each side. In a patient with severe postoperative nausea and vomiting, you have so many other anesthetics that are better, probably would avoid nitrous oxide. Some issues with nitrous oxide: it diffuses into closed air spaces that have nitrogen in them. Remember, air is 80% nitrogen, basically. And so if you have an air-containing space like a pneumothorax, nitrous can go into that space, nitrogen cannot leave as fast, and the airway or the space will expand. If the space is a rigid space, the pressure will rise. If it's not a rigid space, the volume will rise. An air embolism is an example that the air that's floating through your vascular system will increase in size if nitrous is present. Pneumothorax, for example, a trauma patient. Acute intestinal obstruction, where the bowel will get bigger. If you close the dura of a patient undergoing cranial surgery and trap some air under it, and a patient's receiving nitrous oxide, you can have pneumocephalus occur. If someone has bad bullous cystic disease of their lung, bad COPD, for example, nitrous could go in it and blow one and get a pneumothorax. If sulfur hexafluoride is injected into the back of an eye, for example, in retinal surgery, retinal detachment surgery, you've got to be real careful about when you can use nitrous oxide. Again, after it's been injected, and most will say this is weeks to months, although different books tell you different things about when you can use it again. Nitrous also diffuses into endotracheal tube cuffs. So if you're using nitrous oxide, feel your endotracheal tube cuff sometimes, and the pressure will go up over time because the air in the cuff is nitrogen, and nitrous can diffuse into it. As mentioned previously, pulmonary vascular resistance can be increased by nitrous oxide, and the catecholamine stimulation that occurs with nitrous oxide. We tend to avoid it in patients with high pulmonary vascular resistance, pulmonary hypertension. Diffusion hypoxia is discussed in textbooks, but rarely ever seen because we use supplemental oxygen at the end of an anesthetic. However, if you happen to be in a dental office where a patient was given high concentrations of nitrous oxide, the mask was taken off, and no supplemental oxygen was given at the end of the nitrous-based anesthetic, the nitrous would rush into the lung, dilute the 21% oxygen that's in your lung, and you could have diffusion hypoxia. So supplemental oxygen at the end of an anesthetic avoids this. So nitrous will fill closed air spaces, and this is the explanation. I tried to draw it out graphically. Again, forgive my poor artistry, but nitrous oxide has a blood gas solubility of 0.47, while nitrogen is 0.015, 30 times less soluble. So nitrous will go into a nitrogen-containing space, such as a pneumothorax, venous air embolism, endotracheal tube cuff, middle ear that's blocked, a bowel, sulfur hexafluoride bubble in the eye, and the volume will go up dramatically. 50% nitrous oxide, you can see, can increase the volume of a space quite a lot, and higher concentrations will increase it even more. Future, maybe xenon might be used. However, there are no new volatile halogenated anesthetic agents that I'm aware of in the near future. Too expensive to develop. Inhaled xenon is being used mostly in a research methodology and has been shown to have an effect at the NMDA receptor as an antagonist. Its MAC is not very potent. Some papers will say in the 50% range, some as high as 70%. It's very insoluble in the blood with a blood gas solubility of 0.14, which should tell you that this is like an on-off switch of anesthesia. Since xenon is a noble element, it is not metabolized at all. And interestingly, it has minimal cardiovascular respiratory effects. So here you have a drug that is like an on-off switch, low blood gas solubility, very potent, however, with very little physiologic effects, and doesn't trigger hemorrhage, but it's extremely expensive, and until you can trap the agent and reuse it in an effective manner and efficiently, it probably will not be used in clinical service until it is cost effective. We'll end with that discussion, and I like Shakespeare somewhat, so I found a quote to leave you with. For some must sleep, while some must watch, so runs the world. You are the ones that watch while the patients sleep. Good luck as you take care of your patients, and I hope that you learned something from this two-part series on inhaled volatile anesthetics. Have a good day.